Очень приятно видеть вас.
Взаимно.
Здравствуйте всем.
Здравствуйте. Здравствуйте, здравствуйте, дорогие коллеги. Спасибо, что подключаетесь.
Good afternoon, dear colleagues. I'm very glad to see that you're joining us. I think we'll be waiting for a couple more minutes so that the rest of the participants would have enough time to join us. And in a couple of minutes, we'll start. Joining us today, I welcome you at the 15th webinar of the Virtual Medical Consilium. My name is Dr. Elmira Kurbanova. I'm the coordinator of our consilium. Today, we'll be talking about tuberculosis and mental health. This is a very important topic, and for many reasons, it is left behind. And so we decided to change the situation. So in our agenda today, we'll be talking about the issues that are related to the strategic vision of this problem and about country-specific problems. Without any further ado, I would like to give the floor to Dr. Askar Yedilbayev for the welcoming words. Dear colleagues, hello. Good afternoon. We are glad to welcome you once again on behalf of the WHO Euro. This is our 15th webinar of the Virtual Medical Consilium in the European region. Once again, I would like to draw your attention to the fact that this webinar will include the issues related to clinical management, which is the main area of our interest, as well as some programmatic components. I hope very much that you will find this webinar interesting, and we will welcome any questions you might have to the presenters. You can ask your questions in chat or during questions and answers session. We continue our practice of the Virtual Medical Consilium webinars, and about our next plans you will hear at the end of this meeting. I would like to wish all the presenters lots of success and welcome to the webinar. Thank you very much, Askar.
Я забыла сказать, что, как
I
обычно,
forgot
наш вебинар проводится на двух
to
языках.
let you know that we have the option of interpretation. Today we have some new participants who never joined us before, and today you will have an opportunity to listen to this webinar in Russian and in English. All presentations are available in the cloud, and you can follow the link to access these presentations, and the link will be given to you in chat. We will also make a recording of this webinar, and we'll make it available to you as well. Now, I would like to give the floor to Alexandr Korotych, who will give you a brief update. Thank you very much, Elvira. Dear colleagues, I'm glad to welcome you at this meeting. As you know, the Virtual Medical Consilium is part of the initiative on modified shorter treatment regimens for treatment of tuberculosis. And very briefly, I would like to give you an update of our initiative. As you can see, the majority of countries have finished the enrollment of their patients. Lithuania continues the enrollment now, and this way our regional cohort will have more than 2,000 patients. In the past, we also recommended to the countries who participated in this initiative not to limit themselves by the regional cohort, but also to enroll patients domestically. for treatment under modified shorter treatment regimens in the country cohort. At present, we have 8 countries who follow that countries, that is Armenia, Moldova, Kazakhstan, Azerbaijan, Belarus, Ukraine. The rest of the countries continue the enrollment. So hopefully, with the help of these projects, we will learn more about the efficacy of the modified shorter treatment regimens. We see that patients are finishing treatment and they will be offered follow-up, and we decided that now it is a good time to start the intermediate evaluation of the project and to assess the impact of this initiative on the programmatic management of patients with drug-resistant tuberculosis. Also, it is a good time to describe our experience and to assess the implementation of this project at various levels and to find out possible obstacles. We also plan to give some recommendations on the implementation of shorter treatment regimens, BPAL and other treatment regimens, and we plan to document that experience for further evaluation. So here you can see the timeline for our assessment. We developed the protocol of assessment, and now we are in the process of the assessment of the initial documents of the initiative. That also includes the quarterly reports of our consultants, reports of the monitoring missions, and we also plan to have interviews with the researchers, and in May and June, we will have some individual and group interviews. We will contact the NTP managers in your countries who will nominate people who will participate in the interview. By the results of the interview, we will develop the report that will be presented at the regional meeting of MSTR. And then we'll gladly share the results obtained. Thank you very much for your attention. Thank you very much, Alexander. And now let us continue with the program of our webinar. And now it is my pleasure to invite Dr. Cassie, who is the technical specialist in mental health, and she will tell us about the burden of mental health problems in the WHO region, European region.
Thank you so much. And can I just confirm that everyone can see the slides okay?
Yes, Casey, we can see everything.
Excellent. Yeah, thank you. It's a real pleasure to have been invited to this meeting. And I'm going to sort of set the scene, I suppose, and just provide quite a brief overview of mental health burden of illness in the WHO European region, as well as a bit of a flavour of system capacity and some of the impacts that we've had recently with regards to COVID. So I'm also going to share today not only regional data, but also global data, because really good quality regional and national data on mental health remains a challenge. The treatment gap that exists between those that need mental health care and those that receive it, and the ongoing stigma that prevents people from talking about their difficulties or seeking treatment, means that the data that we do have is likely to underrepresent the true burden that we see in the region. That being said, we know the global burden of mental ill health is high and seemingly growing. So mental disorders are amongst the leading causes of global health-related burden. Depression and anxiety disorders both ranked among the top 25 leading causes of burden worldwide. in 2019, so that's when our most recent data is from. The burden of mental health issues is high across the entire lifespan and for both sexes and across many locations and settings. And so you can see in the graph on the left, there's particular burden that occurs for young people in that critical age period between sort of 15 and 35 years of age. So adolescence, late adolescence, and early adulthood. And that's a problem because mental disorder can have long-lasting impact on social and economic factors, rising from disruption to education, employment, and relationships during that time. The other thing to note is that we really have seen no reduction in the global burden since 1990, despite pretty compelling evidence now of interventions that reduce the impact of particularly depression and anxiety. So in fact, the global burden of mental disorders appears to be growing. And this table here shows prevalent cases, years lived with disability, and disability adjusted life years related to mental, neurological, and substance use disorders. They're listed down the left-hand side. Noting that these data are a few years old now, but there's a clear increasing trend across almost all these indicators between 2005 and 2015. And in Europe, we have a similar picture. So the graph on the right shows prevalent cases in millions of mental and behavioural disorders in the WHO European region between 1990 and 2015. These are taken from global burden of disease data. So as we would expect, depression and anxiety, common mental disorders, consists of approximately half the prevalent cases that we see in Europe. 15% of these cases are among children and adolescents up to 19 years of age. Then we have about 52% among adult population up to about 55. When we look at data on years of life with disability, and this is more recent global burden of disease data from 2019, you can see mental health and substance use disorders accounted for almost 20% of all years lived with disability in European region. So depressive and anxiety disorders again accounted for almost 30% and almost 20% of burden respectively, of total burden of mental health and substance use disorders. And by age and sex, burden was consistently highest amongst women in the 30 to 49 year age range. So an age range where women are generally caring for children. I know it can be quite difficult often to think about, what years of life lived with disability actually means. But for those experiencing mental disorders, the disability experience can have enormous costs, not only for them as individuals, but also for their families, their communities, and for society more broadly. So we're specifically talking across the life course about impacts related to school attendance and school dropout, to poor education outcomes, workplace absences, reduced productivity at work, loss of employment, social exclusion, and certainly greater reliance on health and welfare systems. And it's a similar picture here with the data on disability adjusted life years from 2019 again. Mental health and substance abuse disorders accounted for roughly 9% of total DALYs in 2019, the WHO European region. I think notable here, and you'll see on the graphs, is that there's quite a difference in where that burden lies across the sexes between men and women. So DALYs caused by depression and anxiety are much higher for women than men, while for men, alcohol and other substance use disorders account for the greatest disability. So Accurate data on suicide is another challenge that we face in mental health, again, due to stigma, but as well as that inconsistencies in the way that data is recorded and reported on, and the lack of surveillance systems in most countries and regions. We do know that in Europe, suicide rates are high, with the most recent global health estimates data showing that suicide rates are actually higher in European region than the global average, and that we have the second highest rate of all the WHO regions after APRO. So the age standardized suicide rate for the European region is about 10.4 per 100,000 population. That's for 2019. There's a big difference between men and women, and this is a difference that we see across many countries and regions. So for men, the rate is 17.1 per 100,000 population. For women, it's much lower at 4.3. And there is also a big range across the region. So this most recent data has a range between just over 2 per 100,000 population up to about 21.7. What concerns us most, and why there's a large focus on youth mental health at the moment, particularly in our regional office, is the high rates of suicide and self-harming young people. Self-harm has emerged as a leading cause of adolescent mortality and now accounts for around 15% of all deaths in people aged 15 to 25 years in the European region. That is around 4,000 deaths per year. So it's important to say, in looking at this data, that while the burden of mental disorders is high across our region, our systems really are still not robust enough to meet what is the current demand for quality mental health care, as well as prevention and promotion activities. According to the most recent WHO mental health atlas data, this is from 2020 now, we only have about 34% of our countries in the European region with a mental health policy and plan which is fully in the process of implementation and fully compliant with human rights instruments. Only about 60% of our member states had functioning mental health promotion and prevention programs, and 50% of our European countries had no national suicide prevention plan. It's estimated that around 1 in 4 people with severe mental health conditions, including things like schizophrenia and bipolar disorder, are actually not being served by mental health systems at all. And that gap is widening. One of the reasons that we're seeing it widen is the impact of COVID. And just to say something about COVID, it's really highlighted, I think, for everyone that our mental health systems were already under considerable strain before the pandemic hit, and really proved to be not fit for managing the increasing demand for services and support that emergencies bring. Another reason why this is a core focus of our work now. The direct and the indirect impact of COVID has contributed globally to high levels of stress amongst populations, increased symptoms of mental disorders, and particularly symptoms of anxiety and depression, so those more common mental disorders. And what's highlighted for us is that the impacts were not equitably felt, and this has been something that is also an important lesson learnt in the pandemic. So we see disproportionate impact on particular populations of people, so young people, women, carers of young children, people with pre-existing mental and physical health conditions. And also we've seen an enormous impact on our mental health workforce and our health workforce more generally, and frontline health workers. And this is concerning because their mental health was poorer than the general public before. These are stressful jobs, and we've seen a real increase in the amount of stress that those groups are under at the moment. But to end on a more positive note, I think what COVID has brought us is also some new opportunities. You know, certainly there is a new interest and momentum for moving forward to strengthen our mental health systems and services and really make sure that they're fit for purpose into the future, and that we're focusing on those prevention and promotion activities that that really have been lagging behind. So I'm going to leave it there and hand over to our next speaker, but thank you so much for allowing me to speak this morning.
Большое спасибо, госпожа Редлих.
Thank you very much, Dr. Redlich. And without any further ado, I would like to give the floor to Dr. Sayohat Hasanova from the WHO Bureau, who will share the information on the key aspects of social and psychological support of people with tuberculosis, HIV, and viral hepatitis. Hope you can see my presentation well. Good afternoon, dear colleagues, dear friends. Thank you for an opportunity to make this presentation. And to share the data of the review that was conducted in 2019-2020 by the WHO European Regional Office.
Данный обзор или assessment он был проведен по запросу нашего регионального комитета по
So this review was requested by the Regional Collaborating Committee on Accelerated Response to Tuberculosis, HIV, and Viral Hepatitis, and it was hosted by the WHO Europe.
Я очень извиняюсь, доктор Хасанова, это только у меня проблемы, только я плохо слышу.
Excuse us, Dr. Hasanova, we cannot hear you well.
Как слышно?
Да, у нас проблема со связью.
Эльмира, попробуй выключить свой микрофон. Оставь только Sayohat.
Да, я сейчас выключила микрофон и включила, то есть...
Сейчас.
Ой, ну очень хорошо. Я приношу свои извинения.
Well, my apologies for the technical hiccups. Well, like I said, this review was requested by the Regional Collaborating Committee on Accelerated Response to Tuberculosis, HIV, and Viral Hepatitis. It was implemented in 2019 and 2020. The aim of this review included review of available practices on psychosocial support provided to people with TB, HIV, and viral hepatitis. Another aim was to understand the role of psychosocial support in the continuum of care. And the third aim was to enhance and sustain psychosocial support services within country and culture-specific settings. As for the methodology of this review, we did the literature review, revised and analyzed of about 48 research articles and reports. And we also assessed qualitative and quantitative data from 24 NGOs from 10 countries of the WHO European region. Here you can see the list of agencies that provided the information for our review. Before I share the main results, I wanted to give you a definition of the psychosocial support, which is any form of support that is aimed at helping people to overcome the arising or ongoing psychosocial and emotional problems and rebuild social infrastructure. Psychosocial support includes psychological services, social services, and mixed services. The analysis implemented in our region showed that psychosocial support is part of the care provided within the patient-centered approach. The importance of psychosocial support is implemented in the number of strategic documents and policies at the global and regional level, such as Global Health Sector Strategy on HIV WHO NTB strategy, global health sector strategy on viral hepatitis, and so on. Here on this slide, you can see the list of all policies that we use in our review. We wanted to analyze the impact of psychosocial support on the society as a whole. And the data we collected showed that psychosocial support is an important part of the continuum of care. It enables people to have a better response to the disease. It enhances and improves treatment adherence and the overall quality of life, which in its turn gives better treatment outcomes and leads to lower failure and loss to follow-up. On this slide, you can see the words of one of the respondents who said that when a person's days and nights are spent fighting the means to deal with different arising needs or fears, dying of TB, HIV, and viral hepatitis can seem only a distant threat. Of course, the role of families is very important in provision of psychosocial support. We also noted that families can contribute to meeting the needs of people affected by the diseases. However, various effects of disease burden on families, including economic, social, and mental health issues, lead to stigma and social isolation, caregivers' burden, and poverty.
So, where can people get psychosocial support? Psychosocial support is provided in inpatient facilities and outpatient facilities, and they differ a bit. In inpatient facilities, this support is provided within general healthcare. It is well organized and well structured, and it has also measurable parameters. And the key attention is paid to adverse events of the therapy, the understanding of the status and acceptance of the status at the early stages of treatment. On the outpatient stage, psychosocial support is based on multidisciplinary approach. It is accessible at the community level, and it helps to deal with socioeconomic problems, interpersonal issues, and various gender discrepancies. And it also helps to fight against stigma and discrimination. On the outpatient stage, psychosocial support is provided mostly by non-governmental organizations or by governmental services. And the analysis revealed that organization and the structure of psychosocial support on the outpatient stage, where it is provided predominantly by the community-based organizations or civil society organization, is more guided by the needs of the patients than the psychosocial support provided during the inpatient stage of treatment. Here you see the key interventions as part of the psychosocial support provided in our region. You see that there is a wide range of various interventions, consultations on various health issues, psychotherapy, assessment of cognitive and individual needs of patients, various interventions, so using individual peculiarities, individual and group support. This is support to fulfill various needs. It's the childcare, labor support, educational support, social support, and benefits payment. And psychosocial support in the region is also provided either as individual support or as a group support. I would like to inform you about the key results of the review, and therefore would like to bring up to your attention the differences between the psychological support, social support. Psychological support is aimed at supporting the psychological and mental state, affecting social, emotional, economic determinants of mental health, and includes such types of support as support provided to people who fear death, managing adverse effects, hypochondria, problems with the family issues and marital issues, fighting against stigma from the society, also loss of sense of meaning of life, and helping to build positive outlook treatment and the life after treatment. So social support is aimed at solving socially significant problems, such as loss of job or financial issues, taking care of family members, organization of childcare, poor social support provision, malnutrition, lack of dwelling, violation of human rights, stigmatization, discrimination, and various legal issues. And there is also a mixed type of support when simultaneously they deal with social and psychological issues. And we see that many organizations provide psychological, social, and mixed type of services and support, but without their strict subdivision. About 1/3 of organizations provide social support, and among the options of social support, perhaps the highest demand is for legal support, for example, with documents to receive benefits or some state services. This support is provided at the level of local communities. And the local communities and civil society organizations mostly provide referral support when they refer to the organizations equipped with psychologist or testing facilities. Psychological support, as you know, is the service provided by properly trained individuals. But unfortunately, there is not enough well-trained and well-qualified psychologists and social workers to fill the gap and to satisfy all the needs. And therefore, civil society organizations can also provide some support to promptly react to the needs. Here you see the key measures and interventions of psychosocial support, which include education and raising the literacy level, social support, financial support, emotional and psychological support, and also legal support. I won't touch upon the description. You will receive the slides and you will be able to read for yourself. Who are the providers of psychosocial support in our region? Those include groups of specialists, faith organizations, volunteers, non-governmental organizations, state borders and state services and state offices. And I would like also to mention that in addition to providing HIV-related services, TB-related services, we have state committees on women and youth, and they also provide psychosocial support. Another provider is a group of individual workers or specialists, and also the Red Cross and the Red Crescent societies. As for the types, they include official services provided by healthcare workers or social workers, and unofficial services provided by care given by faith or religious organizations or non-governmental bodies. Here we analyzed the risks and also the perspectives for sustainable development of psychosocial support provision. The majority of services on psychosocial support is implemented in partnership with civil society organizations. with the leaders of the community, local authorities, and some state organizations. And we have examples of well-established collaboration between civil society, governmental bodies, and local authorities. But the majority of psychosocial support is provided within standalone projects and funded from external sources. There are certain examples of funding of psychosocial support from national budget, but unfortunately, this mechanism of using local budget are at the nascent level, the early development level. But such examples can be seen in Georgia, in Ukraine, Belarus, in the Republic of Moldova, and Tajikistan, but they are at the early development stage. And at the moment of review, there were no consecutive data on the costs of additional psychosocial support to calculate all the expenditures and plan the stable provision, sustainable provision of services. But as far as I know, this type of cost assessment has been already performed. Here so you see the directions for future research. And those directions were selected based on the review performed and based on the analysis. We also developed an action frame for revision. It consists of several parts. Part one is recommendations on actions aimed at the strategy and policy. It's important for the psychosocial support to be an integral part of the national strategies and national plans with its separate budget to ensure sustainable development. And it is necessary to develop the capacity of psychosocial support. And this capacity development should be also part of national strategic planning. And we can also, we should ensure interdisciplinary provision of services. There should be collaboration between the Ministry of Health, Ministry of Social Policy, or social well-being. And there is some also support with staff for us to be able to deal with social and psychological issues simultaneously. Part two of this action framework pertains to methodological recommendations and training. It's important for psychosocial support issues to be represented in the national guidelines on the management of three diseases. And they should be also included into the curricula of medical institutions and institutions which prepare social workers. And part three of the recommendations pertains directly to the service provision on psychosocial support. It's important to establish comprehensive support system which will bind together and coordinate all the existing psychosocial support services. We should also develop various models of service provision, and we should identify the roles of each member of these multi-profile teams. And we also should develop the packages or standards for psychosocial support, and we should satisfy the needs. And using this opportunity, I would like to thank all the contributors, all the people who participated in this review. I would like also to express our gratitude to Safarali Naimov, who contributed much. And I would like to thank also Oksana. I know that she is part of today's meeting. I would like to thank you once again. Thank you very much, Sayohat. Thank you for such an important overview and the well-formulated recommendations in regard on in which directions to move forward in developing the system of psychosocial support. I believe that it is really important. I will pass the mic to Dr. Alexandru Stoichita, who will present very interesting outcomes and findings of the survey on the prevalence of depression and anxiety in people who receive treatment in the National Institute of Pulmonology in Romania. Before I pass the mic to Alexandru, and before he starts his presentation, I would like to remind you that interpretation is available from English to Russian, vice versa, and from English to Romanian. Please, those of you who have just joined us, select language or switch to the language you prefer. Dr. Alexandru, please, the floor is yours.
Hello, everybody. I will be presenting a clinical study done in partnership with the World Health Organization and the Institute of Pulmonology in Bucharest, Romania, regarding the mental health of TB patients, namely depression and anxiety symptoms among people with rifampicin-resistant tuberculosis receiving inpatient care in the National Pulmonology Reference Institute in our country, Romania. As we know, tuberculosis...
Alexandru?
Yes.
Sorry, you have a small problem. We don't see your full screen. Let me present on your behalf, and you just tell me when to switch the slides, okay?
Okay.
Mm-hmm.
Please
go ahead. Yes, please go ahead.
Mm-hmm. Okay. Can you change? Okay. As we know, tuberculosis is remains one of the major public health threats globally, affecting almost 10 million people annually. Romania is one of the 18 high priority countries for TB control in the WHO European region, accounting for 23% of all TB patients in the European Union. The rifampicin resistant and multi-drug resistant TB burden in Romania remains a public health concern and challenge, but in the last years there have been significant improvements in the detection and treatment of this disease. You can change now. Separately, the WHO estimated that globally, total number of 300 million people fall ill with depression, and the same number of people suffer from anxiety. So, integrated patient care and prevention services are some of the key interventions in implementing in the national TB program, and include social and psychological support for TB patients. Studies from the World Health Organization European region report the prevalence of depression and depressive symptoms among TB patients ranging from 19 to 65%. You can, thank you. So why is this important for TB professionals? Because mental disorders are associated with poor adherence to medication that could lead to irregular treatments, especially in treatment of illness with long duration. Many people with depression are also exposed to TB risk factors such as alcohol abuse, poverty, homelessness, and congregate housing. Thus, they are at higher risk of developing this disease. On the other hand, TB patients are at high risk of developing depression due to several risk factors, including drug use for the treatment of rifampicin resistant or MDR TB, poverty, social exclusion, and drug abuse. Thus, TB and depression act synergically to worsen the overall disease burden. Our aim for this study was to assess the prevalence of depression and anxiety symptoms among the rifampicin and multi-drug resistant patients that were admitted to our hospital. We conducted a cohort study in which were included only adults that were diagnosed with rifampicin or multi-drug resistant tuberculosis and who signed an informed consent. The study instrument that we used is called the Hospital Anxiety and Depression Scale, HADS, and is used to evaluate the presence of depression and anxiety symptoms. The questionnaire has been validated in many countries, languages, and settings and can be used free of charge. The instrument was not validated in Romania. On the next slide, we can see how the HAD scale looks like. It is composed of 14 questions. 7 questions assess the presence of depression symptoms and 7 for anxiety symptoms. Each question is graded from 0 to 3, and at the end it's done a cumulative score. And the score is divided in 3 categories. From 0 to 7, it's a normal score. From 8 to 10, it's a borderline score. And from 11 to 21, it's an abnormal score. The sources of data that we used were 2 sets. The primary data we obtained from the HADS questionnaire, and the secondary data was acquired from the patient's medical records. Each patient was assessed for the presence of depression and anxiety at baseline. This is the admission. And after 2 months of inpatient treatment, the follow-up using the same questionnaire. The questionnaire was mostly self-administered. Only those who were not able to complete the questionnaire on their own, such as people that didn't know how to read or could not see. The questionnaire was administered by an experienced psychologist that was working at the facility. The results, we included 76 patients, from which only 46 were screened for depression and anxiety, because 39% declined and 6% could not be administered the questionnaire. So what results did we have? You can change, Alex. The mean age of our study population was 46 years, and the majority of them were male, 63%, and 65% of our study population had an education level above 8th grade. And most of them, meaning 54%, resided in rural areas. The majority of our participants were current smokers, 83% of them, and also they reported a high alcohol consumption, 35% of the patients. 52% of the patients that were included in our study had been previously treated for TB. Imaging assessment using X-ray revealed that cavities were found in 1/3 of our patients, and 9% of our patients had diabetes, and 4% had HIV co-infection. The majority of our participants, 78%, had 1 or 2 key symptoms for TB, such as cough, fever, or hemoptysis, and 50% had all 3 of them. In the next 2 slides, we can see an alluvial plot that shows the change in HAD scores for depression and anxiety as at baseline and after 2 months. And the main result of our study concluded that the prevalence of depression and anxiety in our cohort at baseline was 46% and for depression and 43% for anxiety. And at follow-up, so after 2 months of treatment, for depression was 50% and 39% for anxiety. Also, at baseline, almost 28% of the patients had both anxiety and depression, and at follow-up, 22% had both mental disorders. You can change, Alex. Can you hear me? Okay. The results that we obtain are similar to other studies that were conducted globally, such as a meta-analysis of 5,000 people from 7 different countries, and that study obtained a similar prevalence of depression. We obtained 46, they obtained 45, with a high prevalence among MDR TB at 52.3%, 34%. In contrast, there were other studies conducted in Romania that found that at baseline, the prevalence of depression among almost 400 drug-sensible TB patients was 22 for a baseline, which decreased significantly to 11% at the end of the TB treatment. The study revealed that there is a high prevalence of depression and anxiety among rifampicin-resistant and multi-drug resistant TB patients admitted to the Institute of Pneumology Marius Nasta. This calls for a routine assessment of all TB patients for depression and anxiety and linking them to appropriate care. This is likely to improve the overall quality of life for TB patients, complementing the evaluation and the potential rehabilitation of post-TB treatment sequelae, as recently discussed with the scientific community. Further research on depression and anxiety with a higher sample size is recommended to estimate independent risk factors for depression and anxiety, as well as factors associated with the change in the depression and anxiety score during the course of a longer treatment duration. Thank you for your time.
Огромное спасибо, доктор Stoichita. Очень
Thank you very much, Dr. Stoichita. These impressive results, and it's a pity that more than half of our patients at baseline experience depression and anxiety. This should trigger provision of psychosocial support to these patients. And an example of such a well-established work and Romanians example in managing mental health disorders in TB patients will be presented by our next speaker, the head of the National TB program, a person who works in the National Pulmonology Institute, Marius Nasta in Romania. Please, the floor is yours.
Hello, everyone. I prefer to speak in Romanian language. I think it's we have the support for translate. România, dacă privim harta de supraveghere publicată de TESI în 2020, are o incidență a tuberculozei crescută pentru Europa de Est sau pentru Europa, dar undeva o medie pentru toată regiunea OMSE
в Румынии на период
publicate în cadrul...
I'm sorry, Dr. Machler.
Yes?
Apologies, I must speak to translator. Dear translators, we don't have English translation right now. Whoever is
You
providing. No, just Dana, could you please make sure you provide English translation from Romanian language? Thank you so much, because currently there is no translation to English. Sorry, Dr. Machler, please continue.
No problem.
Mm-hmm. You can continue, Dr. Machler, in Romanian. Thank you. Mm-hmm.
Thank you. Așa cum spuneam, România se găsește într-o zonă de incidență crescută pentru zona Europei, cu o zonă de incidență medie a tuberculozei pentru regiunea OMS-Europa, lucruri care se văd foarte bine pe datele publicate în cadrul Programului Național de Supraveghere și Control al Tuberculozei. România având în anul 2002...
Очень извиняюсь, на русском теперь нету русского перевода.
Just apologies, yes.
I speak in English.
No. Just try to just let us fix it. Dear Dana, you have to unmute.
Все, хорошо, да.
Dana, please unmute yourself. Dana, you are muted. Yes, correct. Please unmute yourself, Dana. You are still muted. If you press unmute.
Deschideți microfonul, Dana.
You should be able to do that.
Дорогие коллеги, я извиняюсь, у нас техническая задержка. Мы буквально в течение минуты организуем перевод.
Yeah, okay. Dana, can you maybe log in and log out again? Yeah. Apologies, colleagues, it's a technical issue.
Еще раз извиняемся, дорогие коллеги. Сейчас мы наладим каналы перевода и продолжим.
Yes, it's a very important presentation, so please bear with us. Just give us a couple of seconds to fix the translation. We are waiting for the translator to join. Dana, can you log out and log in again? Yes, Dana, you are assigned as an interpreter from. Otherwise, what we can do is to ask Mila and Tatiana to translate from Russian to English. Tatiana, can you do that? Or Mila? Tatiana, Mila, I'm in the English channel. Can you please confirm you can provide translation from Russian to English using the translation channel from Romanian to Russian?
Если возможно, тогда, получается, мы можем продолжить, да?
Let's try it. Yes. So the translation will be provided from Romanian to Russian, and then Mila or Tanya will provide translation from Russian to English. Thank you, Dr. Machler. We apologize for the inconvenience. Please
Thank you very much. We continue. Incidența globală în România din 2002 până în 2021 este în continuă scădere, așa cum se vede în acest grafic. Este un trend descendent, cu o scădere accelerată, așa cum a fost percepută la nivelul întregului glob în perioada din momentul în care a apărut pandemia, în anul 2020, dar cu o revenire ușoară în anul 2021.
With a slight comeback in 2021. 2002, when the incidence of TB has reached the highest level yet in history, or at least in the history of data we currently have in Romania, well, from that moment on, not only the national policy for managing TB patients has changed, but also the international support from the WHO and from the Global Fund and Norwegian funds started to focus on Romania, and together with pulmonologists in Romania, they have concerted reaction and action so that the number of cases continued to drop. The number of cases that, well, this decrease has been seen both in new cases and relapses. Unfortunately, relapses are still quite high compared to the number of cases. Practically, last year, Romania had 7,600 TB cases, of which 1,200 cases are relapses. This is a small number compared to the level we started from, namely almost 31,000 new cases, but sufficiently high, given that in 2019 we started from a number of approximately 11,000 cases. This is the map of Romania. You see it in different colors. The red colors shows an incidence of more than 50 cases per 1,000 inhabitants. The yellow between 35 and 50 cases in 100,000 inhabitants, and in green, the central area of Romania shows us the counties where the number of TB cases is less than 35 in 100,000 inhabitants. The biggest concentration of TB cases can be found in the eastern part of Romania, which is close to Moldavia, and in the south part of Romania. Things are a bit unexplained given the geographic position and the neighbors, because the Bulgarians have a very low TB incidence compared to Romania. It is virtually a number of very high cases in a place in Romania where, at least geographically speaking, is not justified or cannot be explained. In terms of MDR TB, Romania doesn't have such a high number of cases. We started from almost 100 cases in 2008, and we've gotten to 300 cases in 2019. And I believe that the significant number is the one in 2019 because we have a low number of MDR-TB cases detected in 2020 and 2021. A number of cases which, unfortunately, for 2021 is still decreasing. Although Romania seems to have a small number of MDR-TB cases, and although the number of TB cases is low, all these things have been done because the Romanian state, and rather the NGOs in Romania, have tried to obtain for the TB patient in Romania everything that was best for them. They tried to prioritize the state of health of the patient. So in 2018, Romania adopts the law of tuberculosis. It is a law that allows patient access to psychosocial support. This is a reference point, a benchmark in the TB patient care in Romania, because until that moment, according to the legislation, the hospitals in Romania, or in the hospitals of Romania, you would not have psychological support for TB patients unless you were an MDR center. And only one psychologist would be available to provide support to all admitted patients. Things have changed, at least on paper, but the reality in hospitals hasn't changed much. Let's see what we do now to change the reality in hospital. We have a screening project in Romania right now. We have 4 caravans in Romania providing a screening of the population at risk, meaning the population that is in rural areas and have difficult access to healthcare, homeless patients, and inmates in prisons or jails. In this project, we want to screen 75,000 people, and we want to educate 560 employees working in social areas and social fields, and those who provide psychological support. We are not alone in this. This is a European project, and we have several partners, associations of patients, ARAS, Romanian Angel Appeal, CPSS, and ACPTMR, and we have actually 6 partners, each of us playing a very well-defined role. CPSS and Romanian Angel Appeal are associations helping us, bringing people to the caravans. They prepare the rural communities and inform them on when the caravan is going to be there so that the patients can go to the caravan to get their x-rays, and in case of any suspicion, they can have their sputum collected so that they can be subject to the lab tests. Well, the other organizations actually support the patient during their treatment, and they monitor their treatment adherence or compliance. The diagnosis in the caravan is made by the X-ray test. We have an AI software developed by a team of young IT specialists in Romania, and they help to diagnose not only TB, but also other respiratory diseases. These caravans are highly welcomed, and especially in the rural areas of Romania. As regards the psychological support of patients, UNOPA has 8 multidisciplinary teams that act in the 41 counties of Romania, plus Bucharest, in the 8 regions. And these are defined as regions so that it can help us split the territory of Romania into several parts. ASPTMR, they support with psychologists that can help TB patients, those people that are at risk of abandonment. So these teams provided by UNOPA and by ASPTMR, they help patients at risk of abandoning the treatment, or patients with several drug addictions, or have social conditions that are quite difficult, so that we can improve the compliance to the treatment and bring them into joining the full TB treatment. ARAS and Samu Social, these are 2 NGOs helping us with the most difficult category of people, namely patients that are homeless and are drug users, drug abusers. Even if we can identify them, and so we can get them an X-ray and a sputum sample tested, they simply disappear when it comes to treatment. That must be taken every day for 6 months. And things are quite limited here because, on the one hand, it is difficult to make patients adhere to the treatment and accept the social support given by the authorities, but also a very limited involvement of the authorities to provide social support to such categories of patients. This is the screening map. The Marius Nasta Institute, together with its partners, is reaching patients in Romania as shown on this map. 2018-2019, that's when we started the project. Actually, it started in 2020 and 2021, where the screening focused on several counties, the ones in purple. In 2022, we have a large area to cover, and in 2023, because the project will last until March 2023, we have just 1 county proposed for the year of 2023. Let's see what we did so far. Of 75,000 patients, we screened 46,754 persons until December 2021. the EMD support teams assessed more than 2,000 TB patients, and we educated 344 employees. Like I said, artificial intelligence, AI, was highly welcome when we needed to use it in rural areas, because 18% of people of these 46,000 persons that were involved in the screening had problems not necessarily with TB, but other respiratory problems that required some specialist consultation by physicians dealing with chest diseases. As project results, I can tell you that the data shows something completely different from what the national data presents. They are approximately similar when it comes to inmates in jails, and that's where we have projects and we have assessment of inmates that are highly rigorous. But when it comes to rural areas, well, TB has been detected with an incidence rate that was 5 times higher than the national incidence rate. Therefore, Romania has taken significant steps in providing psychological support to TB patients, but for sure, this is not enough. The fact that we do have legislation in the field is helpful in making sure that we can take steps forward more easily. However, the experience we have right now under the TB screening project shows us that the psychological support these patients need must be significantly enhanced, because it is not enough to have just one psychologist for one TB region. A TB region is includes almost 2 million people. Not as many TB patients, of course, but it takes much more psychologists getting involved with these patients. I would say that the most difficult problem is related to patients that are drug abusers, because it takes not only psychological support for these patients, it also takes admission to hospitals. They need to be admitted, they need to be provided the right to health for such people as well. But we also need to take into account the fact that these people are highly fragile and they do not understand, and they would not always accept the social support providing to them. They refused treatment, and unfortunately, they become aggressive towards healthcare professionals. I hope this situation will be solved for a period at least. We need interventions from various directions that focus on this very fragile segment of assistance or healthcare for TB patients that are drug abusers. Thank you.
Thank you very much.
Спасибо большое, доктор.
Thank you very much, Doctor, for sharing your experience and also for telling us not only about your success, but also about the challenges that you came across with. And we believe that those countries that have just started planning similar services will consider these challenges in advance. We have a little bit more than 10 minutes left before the end of this webinar, and I would like to invite all participants to join the discussion session. Should you have any questions, please ask them either in chat or you can unmute yourself and ask questions. I see one question already and I can read it. This is a question from Dmitry Butov to Dr. Stoichita. Did you include into your study only new cases of tuberculosis, or you also included cases of relapses and cases of treatment failure?
We included also relapses and TB treatment failures, not only new TB cases.
Спасибо большое.
Thank you very much.
You're welcome.
Do you have any other questions? I don't see any raised hands and I don't have any questions in the chat. And probably I will ask this opportunity and ask Beatrice a question. So you have identified a very special challenge related to the work with patients who are injectable drug users.
Yes.
Can you tell us whether you use substitutional therapy in your program? Perhaps you
Yes.
collaborate with other agencies, so
Yes.
please tell us some words about it.
We have this type of collaboration because our partner support this patient, but we have a difficult problem because not always the patient accept the substitution. Usually they want to have the substitution medication and take supplementary the drugs. It's very difficult to manage this type of patient in the hospital with the same patient with who not have this addiction. I think for this patient who is very special, we need special condition, special support. I don't believe in the success of this treatment if this patient not have the special places where the multidisciplinary team to be involved. Psychiatrists, psychologists, pneumologists, and usually they have two other disease, and they have to attend of this type of specialty. And I think it's very important to think to all our patients to have in the hospital a state of well-being, because usually the patient take the medication in the morning and in the evening they don't have anything to do. And this is a very serious problem because the bad mind, gândurile, ajutați-mă, gândurile rele, but feelings, it's not a very well support for their health.
Огромное спасибо, очень отрадно слышать это.
Thank you very much. I was very glad to hear that from a representative of the National TB Control Program, the head of the TB Control Program, because usually we hear physicians who ask these questions and not always the leaders are aware of this problem. So thank you very much for your answer. I don't see any other questions in our chat, and we came to the end of our meeting. So I would like to thank the presenters. Thank you very much for very interesting information shared with us. Thank you for the interesting data, and I hope that it will be a trigger for the further development of psychosocial support in the region. Thank you very much. And in conclusion, I would like to give the floor to Dr. Askar Yedilbayev from the WHO Euro. Thank you very much, Elmira. Thank you very much, dear colleagues, dear speakers. Thank you for highlighting this very important topic. I hope that in the nearest future, we will share the information on the future webinars, which will be focused on very important topics and dedicated to the new WHO guidelines on childhood TB and treatment tuberculosis in children. The future webinar will be dedicated to the World TB Day. We'll have it on the 1st of June. That will be part 1. And the second part of this webinar will be scheduled for the end of June. We believe that this webinar will be useful for you. The guidelines we issued just recently, and they will be of a lot of practical importance. Thank you very much and see you next time. Good luck and goodbye.
Thank you very much.
To the translators.